Welcome to The Brief Therapist with Tom Skotidas. Our podcast is dedicated to making psychotherapy accessible to everyone. In this series, Tom shares evidence-based psychotherapy strategies designed to improve mental health for individuals, enhance couples' relationships, and repair family conflict. Whatever mental health or relationship challenges you're facing, The Brief Therapist with Tom Skotidas offers the insights and tools you need to cope effectively and thrive. This podcast is provided solely for educational and informational purposes and is not intended as a substitute for professional advice, diagnosis, or treatment. Always seek the advice of qualified health providers regarding any mental health or relationship concerns you may have.
Welcome to The Brief Therapist with Tom Skotidas. I'm Tom Skotidas, and today my co-host and I will be talking about perimenopause and its impact on physical and mental health. It's my privilege to introduce my co-host, Dr. Talat Uppal. Doctor, welcome.
Thank you so much.
Could you please introduce yourself for the audience?
Thanks, Tom. So I'm a gynecologist and I'm based on the northern beaches of Sydney. We've set up a multidisciplinary model of care, and basically it's a hybrid support. My clinical interest is management of abnormal periods in women. I also have a research and an advocacy focus in the same angle.
Well, it's great to have you here, Doctor.
Thank you.
I know that I've been exposed to perimenopause through people in my life, and there's someone very close to me who's going through perimenopause as we speak. So it's meaningful to me. And I have been shocked as I continue to learn about perimenopause, just how underdiagnosed it can be or misdiagnosed. I was wondering if you could share your experience in terms of misdiagnosis or lack of diagnosis, and what are the key symptoms that women should be considering as part of reviewing what they're going through?
First of all, I think it's so good for you to share and have the courage to share the journey of loved ones and those close to you, and that what it has made you reflect on. And this is indeed how sometimes positive change occurs when we question the status quo. So I would like to take a step back and first of all say that I might be using the word woman, but I mean it in a very inclusive sense to include everybody with or people with a uterus. And secondly, I thought, Tom, let's start with some statistics to give a bigger context. So the average age of menopause in Australia is 51 years. Okay, menopause technically means a year since the woman's last period. Time prior to that and the 1 year just after the final period is called the perimenopause. Now, more and more studies are showing that this could start 8 years, a decade prior, a few years prior. So we're moving the focus away from just the time when the woman is no longer bleeding to actually what's happening in the time leading up to that transition. The bigger numbers are around almost like 20, 60, 20. So on one end of the spectrum, we have women who have basically had no concerns, okay? All they say is that my period stopped and that's it. I haven't had any misery, and which is so, so good. On the other end of that spectrum, we'll have nasty and debilitating awful symptoms. And so they are really, really, sort of disadvantaged by this perimenopause transition, and they are miserable. And in the center is the majority of women who will say, look, we have had some good days, some bad days, some variation, and they still are reporting symptoms, but tend to be more manageable than the prior cohort I mentioned.
And what are the most common symptoms of perimenopause, Doctor?
The earliest and the most common feature is a change in their periods. And when we're talking periods, Tom, there are a number of different angles. How heavy is the flow? How frequently are they coming around? How long are they lasting? Is that pattern regular and predictable, or is it totally erratic? So there are a number of things that we have to keep in front of mind. Heavy menstrual bleeding is quite common. It affects 1 in 4 women of reproductive age, and it is actually more common yet still in perimenopausal women. It can have quite a significant impact on the physical front, on the emotional front, on the social front, and also it could be that the heavy periods, the logistics of managing heavy periods, we know that women sometimes have to use 2 or 3 types of protection. It could be the impact from the iron deficiency or the anemia that could result, or it could be, the bigger picture around just unable to go out as planned, or so many women tell me, I'm unable to go to the beach on those 2 days. I can't go out visiting. I have to miss out on social occasions. So a number of ways that this impact can be quite negative. But apart from the direct impact on periods that women report, they can have what we call vasomotor symptoms, which means that they might have hot flushes, they might have night sweats. And this basically also doesn't do our sleep pattern any favors. And so they can be a primary effect on sleep as well. So poor sleep is notorious in perimenopause. It's a symptom. And also, when we're talking below the belly button, we have what we call the genitourinary symptoms of syndrome of menopause, which basically is a fancy way of saying that whole area below can become quite dry and really more fragile and less supple and less nourished. This then has its own series of issues that it can create. Like, for example, women might report, we're getting up to pass urine more frequently. We're actually feeling vaginal dryness. Sex is painful. And some of the symptoms, Tom, that are an issue for some women are actually skin related, or there are joints and aches, or there's fatigue. So, and very importantly, a change in mood. Some women will say, we're far more anxious. Women tell me all the time, I'm more grumpy. I'm short-fused. I used to be so tolerant. I'm just a different person now. I can't recognize myself. Don't know what's taken over me. The saddest part is that there is so much support available for women, and it's a very treatable space.
Thanks for sharing those insights, Doctor. What mental health impacts are you witnessing with your patients who are presenting with perimenopause?
I'm actually seeing quite significant impact on mental health, and I look at it as a multifaceted space. So I often find that the iron deficiency is really taking women backwards, and once we correct that, once we sort out the bleeding related issues and minimize the bleeding into a much kinder space, once we try and support women if the low estrogen impact and the sleep impact. So it's such a complex space. And as a gynecologist, these are my main targets. I'm very lucky to work collaboratively with mental health trained clinicians. And what I'm finding anecdotally is that once we do have the corrective scenarios in those particular issues, we're then getting traction, and women are coming back saying, they feel much calmer, they feel much more better supported, particularly if they've also had a plan from a hormone therapy point of view, if some lifestyle factor education and support has been provided. So I think we have to really step back and look at the multidisciplinary and the holistic solutions to this situation that women are finding that it's a very uphill time for some. What has been your experience, Tom?
As a psychotherapist, I review the latest research, peer-reviewed research, and a lot of it talks about how perimenopause is associated with mental distress, depression, in one case, suicidality. And I am aware that there are correlations between perimenopause and those mental health challenges. I am also very keen to understand not just correlation, but causation. One thing that I know from my study is that the physical symptoms of perimenopause are directly causative of specific symptoms that are part of a chain that we can infer would lead to mental health challenges. Through vasomotor symptoms like hot flashes or night sweats, of course they would disrupt sleep. But we also know from research that the fluctuations in estrogen impact sleep cycles. So we really have almost a brutal attack on sleep. And we also know from research that lack of sleep, disrupted sleep, is causative of mental health challenges, including mood swings, irritability, and of course, fatigue. So we talk about brain fog. Usually it's mentioned as a direct causation of perimenopause. I'd like to argue maybe it's the sleep deprivation that is causing brain fog rather than fluctuations in estrogen. What is the answer?
I think, Tom, you've highlighted a very, very important point. There is that complexity of what is causing. Is it a chicken egg, or is it related to the hormonal imbalance that is occurring at this time? We acknowledge the lack of data, and there is lots of good work done by Professor Jayashree Kulkarni in Melbourne, who is basically saying, is menopause depression a reality? We need more research to give us answers in this space, and that we should be looking at hormone therapy as well as one of the options of care for women. Anecdotally, I will say to you that I'm constantly seeing women where we've started from a baseline, but we've started them on transdermal, for example, estrogen with the plan, and they're coming back saying, I'm in a better place. Look, it may not be perfect. Obviously, it's not going to fix any external stresses, but it seems to give them better reserve to manage them. And so I find that, definitely we're seeing women whose antidepressants or anxiolytics, the amounts are going down, or if they're completely coming off that. So again, it's not necessarily one thing. I'm also seeing women who are saying, oh, look, you know what, since I started that estrogen, I'm actually walking the dog more. Or that gym membership that had lapsed for so long, I'm actually using it. I feel like going to the gym. So then, we can't take the credit for all of that is just because of the hormones, but it's kind of moved that particular person into a better space. Some of the benefits that we're seeing anecdotally might actually be because of that other kind of space that woman is now in. But at the end of the day, we just want good quality of life for women. And I think the purpose is to offer awareness, good education, combination of solutions, and support women. And it's okay for some women to say, actually, you know what, this is not a problem for me. I just wanted to come for education. I wanted to know, or I feel this is ahead of me in 10 years' time. I want to just get aware. So awareness is also important, Tom. We're not going to be able to help community unless we validate some of the patient journeys. And I know that there is some concern around medicalization of menopause. We know that in Australia, just over 10% of women are on hormone therapy. So if anything, day to day, I'm actually seeing women who are underserved by the system, who there are major gaps for. We're obviously not seeing the 20% of women who are comfortable and happy and so good for them. It's so good that they don't have symptoms. But the reality is that it's our duty of care to care for women who do have significant symptoms and try and not have another generation miss out on potential options. Do you have any theories around causation or any work that you're doing or something to share with us?
I do have a theory of causation, Doctor, that I'm happy to share with you, and I'd love to hear your feedback. I look at chain analysis. Does perimenopause directly cause depression? Does it directly cause increased suicidality? Or is there a chain of events and impacts from perimenopause to that extreme outcome? The key is to look first at the physical symptoms. And we know that fluctuations in estrogen are directly causative of physical symptoms such as vasomotor, hot flashes, night sweats, disturbances to one's sleep rhythm. Therefore, women are getting less sleep. And we know that less sleep is directly causative of mood swings, irritability, brain fog. We know that perimenopause and its fluctuations in estrogen also are directly causative of body aches and joint stiffness. These are symptoms that will cause agitation to the human being. Agitation, irritability, these are normal responses. If we then add in the interpersonal aspect of how these body aches, this joint stiffness, these sleep disturbances, this dryness or urinary symptoms can affect one's relationship with their partner, we can then extrapolate that relationship conflict will arise. Even more so if the relationship already has conflict built into it, unfortunately. The direct causation from perimenopause and fluctuations in estrogen is not to depression, but it is to the woman's response, the normal human response of irritability, anger, disappointment, struggling to make sense of what's happening to her body and how that affects interpersonal relations, which we know conflict can be a really big stressor. So what's happening is these stressors that are taking place are leading to one questioning their own self-efficacy. If we now overlay life stressors that usually happen between the ages of 42 to 51, which are our children leave the house, our career might be in transition or in crisis, our parents have aged and maybe we have to care for them more than ever before. If you overlay those life stressors on top of the organic stressors that we're experiencing because of the physical symptoms, to me, there's no doubt that this human being is literally struggling with their environment and also struggling with changes to their body. And this will call in a question is, do I have mastery over my own body anymore? Do I have mastery over my immediate environment? Or have I lost control? Have I lost my power? And we know that a common or key ingredient for depression is loss of self-efficacy, loss of self-mastery, and the subsequent hopelessness that sets in if the sadness, shame, or fear over loss of self-efficacy becomes prolonged.
So, Tom, I find that very interesting perspective. And I love the way how you've brought almost like an ecosystem approach of the woman's indigenous issues that are happening inside her body, but also connecting it with all the external stresses that she may be journeying through. For example, I had patients who report vaginal dryness, and there is estrogen that we can give topically into the vagina, and it helps that whole area. It nourishes it. And so then combined with, for example, pelvic floor physiotherapy, there are a number of things that we can do to help women in that space. If there are some that are postmenopausally, they're reporting a change in libido, there's also the additional option of trying some testosterone for them. So there are a number of options that we can explore, Tom, with the individual symptoms, and to try, and women obviously need to guide the clinicians to say, look, this is the part that's really important to me and I really need to get this sorted, because sometimes menopause can be such a long list. It's really the patient perspective that is important, because we might think as clinicians, oh my gosh, that would be so important. But to the woman, that's actually not as critical. I also found that in relation to sleep, we often will give transdermal estrogen, will combine it, because estrogen is actually so helpful for most part of the body, minus the uterus. It can be like a fertilizer for that. And it can increase the risk of uterine cancer if it's not given safely with a progestogen to dampen down that risk. And a body identical progestogen, for example, prometrium, can actually be really good for sleep. So it's given at night. So I find as a clinician that tractioning a number of physical symptoms invariably then move the patient to a kinder space and has a visible impact on their mental well-being as well.
And I welcome your approach, Doctor, for talking about the systemic factors in your patients' lives. There are other medical interventions that you can share with this podcast audience that you use successfully for your patients?
So sometimes, because again, I have a more of a focus on heavy menstrual bleeding, we find that, there are certain less invasive surgical options, like, for example, endometrial ablation or removal of a polyp or a fibroid. And that kind of moves that patient into a space where they're not bleeding, or they're certainly not bleeding a fraction of what they were doing before. We restore their iron levels. Basically, Tom, we started a charity-based initiative called Bleed Better, because we wanted wanted to emphasize that this is quite common to help the community become aware that it is a medical issue if you have heavy periods, to try and seek care. There's been a recent study of 5,000 women, and more than a quarter of them have heavy periods. Half of them, Tom, are yet to see a healthcare provider. So they're not always seeking care. When they seek care, the care is not always outlining all the options available to them. And there is an encouragement for us to consider lower tiered options, the less invasive options for women first, prior to thinking of the higher tiered options, like, for example, hysterectomy. So these are some of the support strategies that we have for women with heavy periods that journey through our practice at Women's Health Road. The other thing that I found very helpful for many women is hormone therapy after having an individualized risk-benefit discussion and supporting women of the type of delivery, what their specific, doses and the length of time that they want to remain on it. And it's a very symptomatic focus, but also, Tom, it's about, their bone health, because we know that estrogen is an investment in bone health and minimizes risks of osteoporosis, but their cardiac well-being. So it's not a singular lens for women in perimenopause. It's a time where we say, hang on, what symptoms do you have? How can we help you? But also, can you step back and think of the bigger picture? Are there things that you can do now that your future self will thank you for? So those symptomatic women can also get certain other benefits. We also obviously need to have a discussion around breast cancer and what the implications for using a particular type of hormone therapy might be. And the emphasis is always in trying to minimize harm and have patient choice and shared decision making.
When we talk about best practice delivery of HRT or hormone replacement therapy, what are the key hormones involved in that?
So menopause hormone therapy basically targets the three hormones that are major players at this time. There's estrogen, there's progesterone, and then there's testosterone. But outside these three options are also certain non-hormonal options of treatment during perimenopause, especially, for example, like some women who've had previous breast cancer or certain other women that may not wish to take hormone therapy. So those are available for them. They're also complementary and herbal options. But the two questions that we ask women to consider are, is it safe and what is the efficacy? So Tom, tell me about the psychotherapy angle.
I'd be happy to, Doctor. The first thing for me is acceptance. I find that often with anything taking place in our bodies that we fight it. A critical principle of at least the psychotherapy models that I practice is acceptance of what is taking place. It is within acceptance that we are able to start regulating ourselves emotionally and cognitively. For example, when a woman is experiencing perimenopause and its physical impacts, there might be a lot of unresolved emotions taking place. There might be a sense of fear that is occurring, which might come out as mild, ever-present anxiety, but is driven by a deeper sense of fear, one's mortality or one's ability to control their environment. There could be unresolved shame, perceived social stigma that perimenopause might be equated with older age, loss of vitality, loss of femininity. I talk about the three painful primary emotions of sadness, fear, and shame.
Okay.
Which people usually avoid. With my clients who are experiencing any sort of somatic change, acceptance and being able to give voice to one's feeling of shame and or sadness and or fear, vocalize that and have another person witness that, especially that's powerful if you have that other person. If you don't, the mere vocalization of it, as in, I'm feeling shame because of a stigma that I'm no longer as good as the other. Shame is a comparative emotion. Or I feel fear that I can't have any more children. As you experience that, it taps into something called the paradox of change. If we don't avoid things, but actually walk into them, we begin the process of change.
obviously you want a narrative that's so different. You want it to be like the start of something good. We're living into our 80s, if not longer. How can we turn that around, Tom, and make it a positive time? And in certain tribes, this is what it is culturally, that it's a time where you become a matriarch of the society. I often wonder, how can we turn that narrative around?
I love that. And it's a good segue for me to say that when I work with clients on the cycle of emotions,
Yes.
I will always include joy and gratitude as the final one that we work through.
Lovely.
Because after you've talked about your shame, your sadness, your fear, and you have begun accepting who you are, and instead of avoidance, walking into who you are,
wow,
then the expression of joy and gratitude is the beginning of movement toward the person you want to be.
So almost like a healing, or
Correct.
That's very powerful.
Yes.
Yeah.
And for some clients who are willing to confront themselves even more, even a greater radical acceptance, I often also use chair work therapy, where I'll have clients sit in chairs and actually speak to parts of themselves.
Oh, wow.
Or even speak to perimenopause. So we might put perimenopause in an empty chair.
Wow.
And in another chair,
Ah.
their distressed self sits. The distressed self says, I'm feeling shame. I'm feeling fear. I'm feeling sadness. And perimenopause is listening.
Yep.
And I might have them switch and be perimenopause and
Wow.
respond back as perimenopause and explain why it's here. Of course, it's important to track a client and make sure that as they're going through this journey that there's no hyperarousal or hypoarousal, because this can be a very intimate topic. But in the hands of a well-trained therapist or a supportive family member, you can start expressing.
So in a safe space,
Absolutely.
in a safe way,
that's right.
that can address some of the distress.
That's right. I also like to have couples talk about miracle signs. Let's say a couple cannot have the intimacy they want because of the impacts that the woman is experiencing.
Sure.
What is a small sign of a miracle in that relationship that will build positive emotions, connection, pleasure in the couple?
So you're basically asking them to sort of highlight what outcomes they would feel are strategic for them.
Absolutely.
Right.
And these don't have to be big, strategic.
Sure, like tiny steps.
Tiny step.
Right.
It could be as simple as a partner saying, it would be a miracle to me if you simply walked up to me randomly during the day and gave me a melting hug.
Oh, bless. Okay.
Right?
Right.
And we then talk through that.
Yep.
What difference would the melting hug do? And the answer might be, I would feel so safe that my partner loves me, even if she cannot offer me sex. I'm feeling tremendously positive. It's so small, but it could be quite huge for the other partner. When we work on miracle signs of behavior that are very specific, and I go into crazy detail with my clients.
Wow.
Excruciating detail.
All right.
For example, how long will the hug last? So before you know it, we have a set of 5 or 10 miracle signs that act as a body of behavior that protects the couple, builds their connection, even if there are impacts through perimenopause. Do any of those strategies relate to patients of yours, your experience as a doctor? We
are very big on lifestyle factors and sort of emphasizing that at the first go, so that, obviously all the other options I mentioned earlier are important, but as is exercise, as is eating, there's always a role of eating well and nutritional, being mindful of the amount, and also what are triggers for vasomotor symptoms. For example, some women will find caffeine or drinking a lot or, various things that are naturally or spicy foods. It can be quite individualized. And how can we minimize those triggers? The other thing I found helpful is the multidisciplinary approach. I've learned the good value of having a physio included. And then I find that having surgical support for women if they so need. And also very importantly is a urological or urogynecological context as well. It is a time that we sometimes can uncover prolapse. We can uncover things with continence related, both urinary and fecal. And there's lots of help and support for women. And then there's a small number of women that I will diagnose, unfortunately, with cancer. And endometrial or uterine cancer is about 1 in 44 lifetime risk. That is a space as well that we need to support women, try and get a timely diagnosis, try and get very streamlined pathways of support therein. But generally speaking, it's a good outlook for uterine cancer. So there is that desire to have, if we're worried, an ultrasound, make sure the cervix has been assessed and that we're not having any lost opportunities for malignancy that we could have diagnosed early. I'd also like to highlight certain patient information and resources, for example, from the Australian Menopause Society, from our College of ONG, College of GPs. There's also the International Menopause Society. These have both clinician-facing and patient-facing options. So I would encourage everyone listening to this to try and log on and see what is available, all for not only for symptoms, but also for treatment options and for workup of patients. And very, very importantly, at the core of that multidisciplinary model is the general practitioner and primary care. So our nurse practitioners and general practitioners are doing most of the heavy lifting in this space. So we cannot underestimate the role of primary care in the journey of looking after menopausal women, including obviously endocrinologists and so many other clinicians that can have a very, very good role. And I'm hoping that the future, Tom, will be better training to be able to manage this, to recognize this and offer women and community the support they need and deserve.
I agree 100% with the multidisciplinary approach, Doctor. And I want to thank you for your wealth of insights and passion for this topic and for joining me today. I hope this episode serves as a building block to educate more people, not just women, but men as well, and the healthcare industry about this topic and how critical it is to our lives. So thank you.
It has been an absolute joy to be here, and thank you for including me.
Thank you for listening to The Brief Therapist with Tom Skotidas. We hope you have benefited from our insights on improving mental health for individuals, enhancing couples' relationships, and repairing family conflict. To stay connected and never miss an episode, click the follow button on your podcast app. You can also share your thoughts with a review to help others find us. And if you'd like more information on Tom Skotidas or his psychotherapy practice Intermind, please visit www.intermind.com.au.